Is that a winning strategy, or are you seeing price that you pay for larger hospitals too, as one would expect, diseconomies of scale, bureaucracy, inefficiency, complexity? Which of those two strategies do you think is the better strategy, more hospitals or less larger hospitals?
I think that you need to centralize to begin with, to accumulate knowledge and have a sufficient amount of patience and expertise around an issue. And then you have to decentralize the services. So I think we have gone through a lot of centralization, which has had a great influence on skills and knowledge. We have a huge research facility with thousands of researchers working at the hospital, more than 160 professors, nearly 4,000 students just working within this field. And then now our aim is to decentralize the knowledge, to decentralize diagnostic treatments so they can actually be done at home. And that is what we are trying. So we are saying that we have a global problem with workforce shortage, the double demographic pressure, people getting older with more diseases. We can do more, but we are less to actually do it. So we need to do something differently. And one of the things is that it makes no sense that we move people around, neither patient or staff, if it's possible to do it on the distance. So right now we are at the stage where we have been centralizing that much that we are actually able to do things as close as possible to the patient. And for a lot of things, even at their own home. I can give you an example. So during the last years, we have worked with hematological cancers. We have patients from very far away coming to Copenhagen, but now we educate them in how they do mix their own chemotherapy and how they do all the treatment at home. And if there is a problem, we have established a call center. So now for a patient with oncology treatment, they are treated at home. They do it themselves. If there is any issues, they just phone the call center. And instead of using what is close to a year within hospital, they only use 7 days. And this is now possible for all ages. So we also treat parents when their kids have leukemia, for example. And 75% of all our patients is able to do the treatment at the highest quality standard at home. 25% is not, and they are then admitted to hospital because of lack of resources or compliance issue, or simply because they are not feeling safe enough to do it at home. So that's just an example on so what you can gain when you centralize knowledge, and then the purpose is naturally to decentralize it again, so it actually is of benefit for the patient, as close as the surroundings they live in.
That is really interesting, that the whole concept of plurality, fragmentation versus centralization and normalization is a continuum. It's not necessarily a fixed point. I think that's really interesting, that you centralize in order to decentralize. That hasn't been expressed or explained to me in the past, and I really like it. Denmark historically spent 25 years ago, 8% of its GDP on healthcare. And I'm looking up, doing some research real time. In the last 20 years, that number grew noticeably by several points, as high as almost 11% of GDP in 2021. 2023, it came down again to 9.5%, but still, a percentage increase in healthcare spend is noticeable. A 2-3% increase is a revolution. Did that increase happen intentionally? Did the country believe that 8% is just too low a number? There was underinvestment in healthcare. What do you think is the right percentage to spend on healthcare? And I know it's a very loaded question because it depends how that spend is happening. Is it waste? Is it investment? Is it cutting edge? Is it digital? Is it bureaucracy? Is it union wages? Where it's going. The anti-capitalist audience that listen in would argue, is it excess profit? Loaded question. But what do you think is the right number? Use the U.S. as another benchmark where we've been at 17.5% of GDP for 15 years.
It's difficult to say what the right number is. That might vary. I think that the changes you have seen has actually been due to, at a large point, to investment in areas where we needed to renew primarily the diagnostic area in Denmark. And that was largely due to the cancer treatment and what was done in that area. But I will say it short, we don't need more money than we're getting. And the reason for that is that we have already a lot of resources that we're not using probably. So what I'm saying is that we waste our patients' time with some medications that is not giving them the value it should do, some tests, some diagnostics, some treatments, some rehabilitation program that is actually not giving our patients any value. The extent of that, I do not know, but it's large. I believe that. So the OECD has said that 20% of what we're doing is waste. We don't know that exactly, neither do them, because nobody is doing it intentionally. But I can tell you that the majority of a clinician now in Denmark believes that...
By the way, 20% waste is a number to be proud of compared to most countries.
Yeah, but now you said 10% of the GDP. I mean, if the US is 70% of the GDP, it might be a higher extent. But now I'm just saying at what I know about and not going too much into detail about other healthcare systems. But at least when we look at Denmark, the majority of clinicians believe that we actually are wasting our patients' time, are wasting our resources, doing something that is not providing enough value for our patient, and some of it might even harm our patients. So when you ask what is the right number, I will say we should start investing in identifying what is of either low value or is harmful to our patient, stop doing that and redirect it into what is of high value to our patient. And I don't need the government money to do that. I actually think that we can do that together in public-private partnerships, develop these mechanisms that actually identify that. And we're doing that right now. So we are working in something we call platform trials, which is a sort of a research engine where we do the randomized clinical trial with multiple procedures, treatments, tests, whatever. You can actually test what we do in daily clinical life. So that has been built so you don't need to be a scientist to be part of it. So the software has been made easy for the clinician. So when you order something, it says that we got another thing that we're testing right now and prescribe that instead, for example. And what you need when you do that is that you need a huge number. So now we are working with all the hospitals in Denmark, but also in the Nordic countries. That means Iceland, Norway, Sweden, and Finland. And that is not now only 6 million people, now it's 30 million people altogether. And the thing is that we want to make it easy to test daily clinical life in a setting where we can actually say that we test all the antidiuretics, all the anticoagulations, all the fluid therapy, for example. But it could also be all the procedures of rehabilitation or whatever. And when we find out that something is of low value, we can stop it throughout all 5 Nordic countries.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.